Good morning, everyone. So it's always a privilege to be included as one of the speakers in the PIDSP annual convention, and much more a privilege to formally open the second day of our convention. This is our convention, so thanks so much for always bearing with us. So for this morning, I was tasked to discuss with you one of the continuing dilemma in endemic infections, focusing on rabies. So the scientific committee provided several frequently asked questions on rabies management, which we will be trying to address this morning. But for my conflict of interest disclosure, I'm currently an employee of GSK Philippines. So the objective of our discussion is to provide some updates on rabies status in the Philippines, and then we will try to address frequently asked questions in rabies management as provided by our scientific committee. So some rabies facts. Human infection, rabies is a human infection that occurs after a bite, usually from dog and cats. That's the current data here in the Philippines. Although some rabies can also occur after inhalation or of some virus-containing spray or through organ transplantation. So there have been reports of rabies coming from organ donors which turned out to have rabies. So it has been considered, rabies is always considered as a neglected disease, which is 100% preventable, but it's also more often than not results in death. And it is very important for us pediatricians to address this neglected disease, since most of the patients affected belong to the pediatric age group, most commonly those children aged under 5 years of age. So in the Philippines, in 2015, a total of 432,458 animal bite cases were recorded by the Department of Health. So how does it compare within the past 5 years? So I would say we have been successful in managing patients with bites because of the several information drive, and we have seen an increase in the number of bite patients going to animal bite treatment centers. But when it comes to the number of deaths due to rabies, it's sad to say that we have not been successful in decreasing the number of deaths. So it's always in the range of 200, and in 2015, we have recorded total deaths of 226. This is really sad, despite the fact that the Department of Health, through the National Rabies Control Program, has really done a good job in providing trainings not only to private doctors but also to government treatment centers. So the animal bite treatment centers that we have currently in the Philippines is about 480, so that's in the entire Philippines. So when you see ABTCs, these are animal bite centers run by the government. And some good news, in early this year, in January, the Department of Health has announced that they will be providing complete post-exposure prophylaxis in this animal bite treatment center. So it's not only one dose or second dose, but we have money. We have money to provide for complete post-exposure prophylaxis. And one good news also that I want to share with you is the drive of the Department of Health to declare rabies-free places in the Philippines. And as of February 2016, there's already been a total of 33 places declared as rabies-free. So if you notice these areas in the country, like in Apo Island, Batanes Island, in Cebu, in Marinduque, Guimaras, Boracay, Palawan, so Negros Occidental. So if you notice, these are tourist spot places. Of course, we have to address, otherwise we will be importing rabies to other countries, no, for our tourists coming into these areas. And in 2016, they have added or they have declared additional 18 places or areas in the country, such as in Dinagat, and additional places in Palawan have been declared as rabies-free. So that's actually good news. Now, we are on our way in declaring Philippines as rabies-free by 2020. So with the intensive support from the Department of Health, we may be able to reach this rabies-free Philippines by 2020. Now, moving on. So how do we address preventing rabies, especially for those children aged 5 to 15 years of age? The cornerstone of rabies prevention is actually not the provision of post-exposure prophylaxis, but the animal rabies control is the cornerstone in eliminating rabies. So, since we're not involved in this animal rabies control program, you can always collaborate with your city vet in addressing to eliminate rabies among animals. In human rabies control, we have two ways on how to control rabies in humans. One is by provision of post-exposure prophylaxis. So this is the giving of vaccines for those who have sustained the bites. And also, Dr. Betty yesterday has mentioned about provision of pre-exposure prophylaxis, that is giving of the vaccine even before the bite is sustained, most for those who are at high risk of getting rabies. Now, for the frequently asked questions, we will try to answer that later, but in the management of animal bite, I would like to highlight this important specific guidelines. One is do not delay initiation of post-exposure prophylaxis regardless of interval between exposure and the consultation. So whether the bite is sustained a year ago and you don't know the outcome of the biting animal, we have to treat that or we have to provide post-exposure prophylaxis as if the bite happened only today. Okay? But if you know the outcome of the animal bite or the outcome of the bite or the animal which has caused the bite, then if the animal is alive, you don't need to give any post-exposure prophylaxis. Okay? So, and also I would like to highlight that there are no absolute contraindication to rabies post-exposure prophylaxis. So even if your patient is pregnant, because rabies is highly fatal, then you have to give post-exposure prophylaxis depending on the bite sustained. And for special conditions, so if your patient is immunocompromised, then you have to give the post-exposure prophylaxis. The vaccine should be given intramuscular and not intradermal. So for the components of the post-exposure prophylaxis, it's not just giving of the vaccine. It's very important to educate our patients on the importance of local wound care. And then we have to categorize the exposure. So depending on the severity of the bite, depending on the location of the bite, we have to categorize that bite. And then once you know the category of the bite, we're ready to give the immunization. So there are two vaccines that we give for post-exposure prophylaxis. One is the active immunization, where you give the rabies vaccine, and the other one is a passive immunization for patients with severe bites or category 3 bites. So we need to give passive immunization in the form of rabies immune globulin. It's either equine rabies immune globulin or the human rabies immune globulin in order to neutralize quickly whatever virus is there at the bite site. Okay, so what can be done in terms of giving the post-exposure prophylaxis? So I would like to emphasize again the importance of wound care, because as much as 40% of rabies infection rate can be reduced by energetic wound cleaning. So energetic, hindi lang yung, just put it under tap water. So it has to be washed with soap and water, and then you can apply antiseptic after thorough washing of the wound. Okay, so when you categorize a bite, so we have 3 categories: Category 1, Category 2, and Category 3. So the Category 1 exposure, these are feeding or touching of an animal. So all of us with pets have Category 1 exposure, right? So licking of an intact skin is also considered as Category 1. So when you have this Category 1 exposure, no vaccine or immunoglobulin is recommended. So you just have to wash if there is a lick in the intact skin, and we can encourage these exposed individuals to receive pre-exposure prophylaxis. So for Category 2 bites, examples of these are nibbling of uncovered skin with or without bruising or hematoma, minor scratches and without bleeding, and also minor scratches which are induced to bleed. Diba minsan talagang pinanggigigilan yung wound, ini-induce to bleed, no? So if it's an induced bleeding, it's still considered as Category 2 bite. And Category 3 bites are the more severe bites, such as laceration, punctured wound, and we also consider Category 2 bites sustained in the face and neck because of the proximity to the central nervous system as Category 3. Okay? So if it's a Category 3 bite, we have to initiate immediately giving of immunoglobulin as well as the vaccine. So I just want to show this to you. So there are different regimens in the post-exposure prophylaxis as recommended by the WHO. One is the SN or the intramuscular regimen, and where you give the full amount of your rabies vaccine. It's either the purified Vero rabies vaccine or the PVRV, or the PCEC, or the purified chick embryo cell vaccine. So you give the entire amount intramuscularly on day 0, day 3, day 7, day 14, and day 28. And the other regimen, which is the reduced multi-site intramuscular regimen, where you give the 2 IM doses on the left and right deltoid on day 0. And then on day 7, just the entire amount of whether it's 0.5, the PVRV comes in 0.5 ml preparation, and the PCEC comes in 1 ml. So you give that entire amount in day 7, and then the last dose on day 21. So in the Animal Biotreatment Center, what is recommended is the updated Thai Red Cross, because it reduces the cost of treatment by 60 to 80%, because we give the intradermal dose of the vaccine, 0.1 ml on 2 sites on day 0, day 3, day 7, and 1 site on day 28. Okay? So this is being given in the animal biotreatment centers. So what do we do? This is, I think, one of the dilemma, but it's not included in the FAQ, but just wanted to share with you. So the decision to continue the day 28 or day 30 dose for Category 2 and Category 3. So when do you give the last dose? So you give the last dose if the biting animal is laboratory proven to be rabid. So merong examination, no, FAT examination of the head, and turns out to be positive for rabies. If the biting animal is killed or animal died without lab testing, so you don't know whether that biting animal is rabid or not, so you have to give the last dose. And then if the biting animal shows signs and symptoms of rabies, then you have to continue the last dose, even if there is no examination done. And if the animal is not available for 14 days observation, you have to give the last dose. So, on the other hand, you can discontinue the day 28 dose, whether it's IM or ID, if the animal is alive and you can observe the FAT is negative, the animal did not show signs of rabies, then you can discontinue the day 28 dose. Okay, so for our first question, if the patient had received 4 doses of anti-rabies vaccine on day 0, day 3, day 7, and day 14, so IM to, no? After bitten by a dog, can this be considered as pre-exposure doses? Such that if the patient is bitten again, will 2 doses of anti-rabies vaccines be sufficient? Okay, so that's our first FAQ. So I put it together with the next FAQ, which is after 3 doses of scheduled anti-rabies vaccine for category 2, and luckily the child was bitten again, this time on the face. Should you give rabies immunoglobulin or just proceed with the 4th dose? So we have here 2 scenarios where patients receive, the 4th dose, and then the other received already the day 0, day 3, and day 7, and then got bitten again. So how do we address this? So the Department of Health, together with a technical working group, has provided guidance on how to give post-exposure prophylaxis to previously immunized by patients. So it's important to know the history of the pre-exposure and the post-exposure. And then, regardless whether they receive PVRV or PCEC, or whether they receive the intradermal or the IM regimen, this is what should be done. So if the patient receive the complete pre-exposure prophylaxis, no, yung day 0, day 7, and day 28, or the patient receive at least day 0, day 3, day 7, whether ID or IM, using the tissue culture vaccine, so you don't need to give rabies immune globulin, even if it's a category 3 bite. So what you need to do is to give booster doses only. So give 0.1 ml ID dose at one site if it's ID on day 0 and day 3, or one vial, whether it's 0.5 or 1 ml of the IM dose on day 0 and day 3. So that's how to address post-exposure prophylaxis on a previously immunized patient. But if the patient did not complete the 3 doses of the pre-exposure, or the patient received only 1 or 2 ID or IM doses of the pre-exposure prophylaxis, then you have to start the course and give immunoglobulin if indicated. So if it's a category 3 bite, you have to give immunoglobulin, and then you need to complete the course of the post-exposure prophylaxis. Okay, next question is, what is the duration of protection after 3 full dose of pre-exposure or 5 doses of post-exposure anti-rabies vaccine? So we're now being asked on, do you need to give booster doses? So what is the duration of protection from rabies vaccination? So this study have shown the immunogenicity and booster efficacy of pre-exposure rabies vaccination, wherein patients were given PVRV or PCEC as pre-exposure prophylaxis, and then they were given a booster dose 1 year after. So the group A, these are the patients considered as high responders, wherein the antibody titers are more than 30 IU per ml, and the group B are those who are low responders. So if you can see from this, after 1 year, booster dose was given, which is day 0 and day 3, and you can see a very nice rise of rabies virus neutralizing antibody. And this is also true 10 years after. So you can see that 10 years after, if you give a booster dose, obviously, if you get a baseline, the antibody titers will be very low, but if you give a booster dose on day 0 and day 3, so you can see a very nice rise in the rabies virus neutralizing antibody. So whether it's a PVRV or PCEC vaccine that you use. So what about the persistence of rabies virus neutralizing antibody after a post-exposure prophylaxis? So this is a recent study that was done in Beijing, wherein patients were given PVRV as intramuscular regimen, and then after 5 years, they were given a booster dose. So if you notice, after 5 years, sa may aking pointer. Sa may aking pointer. So after 5 years, you can see that 100% of patients had a seroconversion rate. But if you notice, after year 1, 2, 3, and 4, almost only 50% had protective antibody levels. So if you give booster doses, whether it's 5 years or 10 years, you can elicit very good antibody response. So this is what is very good in rabies vaccine. It provides long-lasting immunity against rabies, which is dependent on the immunological memory, which can be demonstrated by rapid antibody responses after a booster dose is given. So long-lasting immunity against rabies is achieved whether you give it as intramuscular or intradermal. And because of this, evidences, regular booster doses are no longer recommended, but you only give booster doses if there is a re-exposure. Okay, I hope that's very clear for now. Now, this is what makes post-exposure prophylaxis very challenging, no? Yung lapse in schedule. So the fourth FAQ is, if there was a lapse on the schedule of administration, do we have to repeat the whole series? Ito, may mga pasaway na pasyente or minsan traveling sila. So to address this, it will all depend in which dose is missed, okay? So again, remember, we have day 0, day 3, day 7, day 14, and 28 for IM. And then day 0, day 3, day 7, 28 for the intradermal. So this is true for both ID and IM. So if the delay is in the second dose, such as the day 3, hindi nakapunta yung pasyente dun sa day 3, so what do we do? So you have to determine the number of days delay. So if the delay is 1 to 2 days from day 3 schedule, such that the patient came day 4 or day 5 from the start of vaccination, so we give the day 3 dose on that visit, and follow the original schedule for day 7 and 28. So kung na-delay siya ng 1 day, let's say patient came dapat yesterday, patient came today is February 18, so give that dose and then just continue on with your day 7, 14, or 28, okay? But if the delay is 3 to 4 days from day 3 schedule, napatagal si nanay, no? So dumating siya on day 6 to 7 from the start of vaccination. So the day 3 dose shall be given upon that visit. So bigay mo na siya, but you have to adjust the succeeding doses according to the prescribed interval. Meaning, if the patient came on day 7 na-delay na siya, so you have to give that dose and then you have to count another 4 days. Kasi yung interval mo between day 3 and day 7 is 4 days, right? So you have to adjust it and then also adjust your day 28. Okay. But if the delay is more than 4 days from day 3 schedule, such that the patient came beyond day 7 from the start, you have to start the new course. So nasayang yung day 0 niya, no? Yung first niya. So, sayang yon. So, you have to start kasi more than 4 days na yung delay niya for the day 3 dose. Okay? So far, so good. Now, if the delay is in the third dose, yung day 7, day 0, day 3, day 7, so that's our third dose. So, if the delay is less than or equal to 7 days from day 7 schedule, such that the patient came 8 to 14 days from the start of vaccination. So yung reference point natin palagi, yung day 0. So the day 7 dose shall be given upon visit and then give the day 28 dose as originally scheduled. So walang adjustments na kailangan ibigay. But if the delay is more than 7 days, up to 14 days from day 7 schedule, so dumating na siya day 15 to day 21. So you need to repeat the day 3 dose. So, di ba, day 7 na siya dapat, hindi siya dumating. So you need to repeat the day 3 dose, balik ka dun sa day 3 dose, and revise the schedule according to the prescribed interval. So bibilang ka na naman ulit ng 4 days, kasi ulitin mo yung day 3. So you need to count 4 days to schedule your day 7, and then schedule again your day 28. Okay? So may sayang. Ito yung sobrang sayang. If the delay is more than 14 days from day 7 schedule, a new course shall be restarted. So nasayang yung day 0 niya tsaka day 3 niya, no? Kasi pasaway or for whatever reasons. Kaya nga it's very important to tell the parents or the patients that they have to follow as much as possible the schedule that is being given to them. Now, if the delay is on the 4th dose or day 28 dose, so just give the day 28 dose upon visit, this will be considered as a booster dose already. Okay. Now, for the intramuscular regimen, iba naman yon kasi may day 14 tayo, di ba? So if the delay is in the 4th dose for IM, so the day 14 dose shall be given upon visit, so irregardless, no? And give the day 28 dose after 2 weeks. So i-adjust mo na lang yung schedule mo nung day 28, which is 2 weeks, no, from day 14 to day 28. So bigay mo pa rin. And if the delay is in the 5th dose, so day 28 dose shall be given upon visit. So irregardless, and that will be considered as a booster dose. And for both regimens, if there are any delays, if the rabies immune globulin has already been given, then you need not repeat the administration of your rabies immune globulin. Okay, so far so good. For our 5th FAQ, if the initial dose of anti-rabies vaccine was given as intradermal, and can the subsequent doses be given as IM? So this scenario is really a very practical scenario, especially now that we have the government animal biotreatment centers where the vaccine is given as intradermal, and then maybe the patient went to travel and then wala siyang makitang animal biotreatment centers. Mostly the private animal biotreatment centers, they give the IM. Or pwede din namang iba yung scenario, no? Initially, the patient was given intramuscular, naubusan ng pera, went to an animal biotreatment center. So what do? So the basis for this recommendation is from the new guidelines on the management of rabies exposure from the Department of Health, published in 2014. So this is our recommendation. So you may come across some recommendations in other countries, like in India, no? Iba yung recommendation nila. So I would like to focus that this is our recommendation in the Philippines. So in the shifting of routes of administration, since there is no immunogenicity studies regarding change in the route of vaccine administration, such that shifting from IM to ID or ID to IM, shifting from one regimen to another is not recommended. So I would like to repeat, this is not recommended. So as much as possible, the initial regimen shall be completed. But in extreme circumstances, that shifting has to be done from IM to ID or vice versa, you need to restart from day 0 using the new regimen. So this is what is being followed in RITM, no? So kung naggaling siya sa IM, sa RITM, it's ID, so magsa-start siya talaga sa day 0. So I added this because I know this can also be a question. What about interchangeability of vaccine brand? So what does the AO or the administrative order says in terms of the interchangeability of vaccine brand? So shifting of vaccine brand shall not be recommended, but may be warranted in the following circumstances, provided the vaccine that you will be using is one of the WHO recommended cell culture vaccine. So meron niyang caveat, no? Pag sinabi mong WHO recommended, dapat nag-undergo siya ng pre-qualification ng WHO. There should be a clinical trial done, published in peer-reviewed journal. So you should be very conscious about this. So you can interchange if there is hypersensitivity reaction, such as generalized rash, anaphylaxis, severe generalized pruritus, or severe local reaction at the injection site, no? So you can shift to another brand, although this is really very, very rare. Or in extreme conditions where there is an availability of the initial vaccine that was used, then you can shift to another brand, provided you follow or you use the WHO recommended vaccine. Okay, so for our last FAQ, after a complete dose of pre-exposure anti-rabies vaccine, the child was bitten by a dog 3 weeks after kawawa naman, no? Buti na lang nag-pre-exposure siya. So what should be given to this patient? Actually, this has been the evidence that you can just give a booster dose was given in our FAQ number 1 and number 2, right? But I would just like to highlight the importance of giving pre-exposure prophylaxis. Again, no? This is the schedule for your pre-exposure prophylaxis. Sino dito ang may pre-exposure prophylaxis? Kasi all healthcare workers. Wow, very good. So, you have received your day 0, day 7, or day 21 and 28 dose, either IM or ID. It doesn't matter, di ba? I've shown you the evidence na whether it's IM or ID or PCEC or PVRV, very good immune response. Okay? But again, you have to give your vaccines in the deltoid muscle or anterolateral thigh in young infants and never in the buttocks, okay? Because of the effect of your fats in the buttocks in the immune response of our rabies vaccine. Okay, very good. So, I would like to highlight the benefit of having a pre-exposure prophylaxis. So yung scenario natin, meron siyang completed pre-exposure prophylaxis. So therefore, booster na lang siya. And these are the benefits of getting a pre-exposure prophylaxis. So the need for passive immunization or getting the rig is eliminated. Ang mahal-mahal po ng rig, especially the human rabies immunoglobulin. So kung may complete pre-exposure prophylaxis, and then there is an exposure, even if it's a category 3 bite, again, even if it's a category 3 bite, even if the biting animal has shown some signs of rabies, you don't need to give rabies immune globulin. Just give the booster dose, okay? So the PEP vaccine regimen is reduced from 5 to 2 doses kasi booster na lang. And of course, this is cost saving kasi you don't need to give the rig, you don't need to complete the post-exposure prophylaxis. And of course, protection against rabies is possible if PEP is delayed kasi meron naman siyang post-exposure prophylaxis. So you just need to give the booster dose and then you can see the beautiful rise in your antibody titers. Okay? So in summary, I would like to highlight again that rabies remains to be a public health problem. It's 100% fatal, but also 100% preventable. And what can we do to eliminate rabies in the country? The provision of the pre-exposure and post-exposure prophylaxis. So kung tatanungin nyo, meron bang provision in the Department of Health for the pre-exposure prophylaxis? For now, wala, but soon, no? I think it's a good step that the Department of Health is able to provide the complete course of the post-exposure prophylaxis, and we really need to follow the guidelines strictly. No? And since the guidelines change over time, it is very important that all of us should be updated. And I know you also want to see a rabies-free Philippines in 2020. So thank you so much for your attention.